the upper lip, there should have been a bleeder or the superior labial artery. On which side of the lip would the superior labial artery be? Mucosa, between the mucosa and the muscle. So that is why when he was cutting from the skin and the muscle, it was not vascular, and then you saw the skip. That skip happened because that was the part where it was bleeding. You put up your slides. We'll make up for the lost time. 10 minutes. Hydrodissection for a Weber Ferguson? I don't think that is possible. You can only in the mucoperiosteal area you can do that, but otherwise the skin. Keep a mic with you.
If you are dealing with a soft tissue, basically it was a malignancy, so we wanted to give soft tissue margins. So there hardly some role of hydrodissection. If you are doing a benign pathology and if you are going subperiosteally, suppose some ossifying fibroma of maxilla, then there is a role of hydrodissection.
So we'll start with a few dialogues. We'll see. So I want audience to also involve in the thing. How to approach this basic practice. Everybody will get trauma, something like this. So if you have a case like this where they have a district hospital sutured laceration as stay sutures and this kind of CT, this kind of comminuted shattered ZMC, where all the 4 processes are gone. What is the approach?
Yeah. Quickly.
Coronal,
okay, then?
coronal. Any other thing?
Hemicoronal.
Hemicoronal, okay. Then?
Bicoronal.
She wants a chocolate also. Yeah.
I did 3/4 coronal, not a
No. Let it go behind. So,
they have to answer. If
yeah.
you can't answer, the question comes
Vinci.
here. And whoever has to answer, please has to answer.
Stand up and answer.
Yeah, quickly. Hemicoronal, okay. Go. What else do you need? Yeah, existing laceration, correct. There's an existing laceration there. What else? Who said existing laceration? Hey, you're here. Oh, sorry. I was the professor who hit chalk. Okay, come on, quickly. We need to wrap this up fast.
Okay, so there are many options. You have existing laceration, coronal, hemicoronal, all of your lower eyelid approaches. What you had? Where is he running?
Sorry. Anybody sleeping? I'll catch them. Okay, come on. Next. Go. Now nobody will sleep.
Okay, so such thing, basic factor what you need to know is okay, so existing laceration, district hospital always have a doubt. So that need to be taken. You need to open up the lacerations and see it. Okay, so such cases where you have a bad soft tissue.
Yeah. Okay. Bye.
Particularly this case, okay? Because there is comminuted ZMC fractures.
The previous one?
As per the literature evidence, whenever the comminuted shattered zygomatic arch, we have to go coronal, bicoronal, otherwise we cannot
Re-establish it
get good result.
completely.
You can go by the old patient है, ठीक है, existing lessons ने अपन थोड़ा बहुत maxillary लिया, but if we want 100% result, we have to do the coronal.
Okay, so consensus, if you want to give an optimum result,
Completely agree. So it is. So for instance, what she was trying to do is she has probably not addressed the arch in that particular case, and she has addressed only the zygomatic complex. So if you want, like he mentioned, if you want to address the arch and the zygomatic complex, so you are getting all your points fixed. Then you need a combination of your exposure. Mainly, if you want to avoid that existing laceration, you just do a bicoronal approach, get a good exposure of the ZMC and fix it.
I have a good experience. I did 20 cases in my last year.
That's
next case.
Yes.
Okay, so
Right.
in
So
this
now, yeah, Sujesh.
Why a bicoronal approach for unilateral zygomatic?
So sometimes what happens is the scalp in an adult is very stiff, right? So when you do a hemicoronal approach, you may not get up to the zygomatic arch. You may have to extend it slightly. So that is, you're crossing the midline. And when you do a question mark by hemicoronal, you will bring it in an anesthetic zone. You don't want that to happen. So you'd rather extend it in the hairline, and that we can come in the next conversation. Yeah. So. Yeah.
Okay, so coming on to the next case, suppose if you have a soft tissue like this, what will be your approach? See, existing laceration, we all know everything is expose if we go from there. What is the area of concern in such bad soft tissue along with a bad fracture?
So come on, there are some areas of soft tissue still persisting, and are you going to violate the whole thing, join all the lacerations together, or just maintain some attachments and then use whatever is exposed? So because you also the Weber Ferguson, so
You can actually highlight what would you do in this case?
We can go through existing laceration.
So will you
connect
connect
all of
all?
them?
No, I mean, why to connect? Because why the reason we wanted to hear from you, which important structures runs in between.
Exactly. So that is the point you need to understand. What is area of importance here? जो वो already नहीं गया. So
You would
that
never connect.
resistance already the soft tissue has given. That area is still retained. What is those areas?
What do you
of
see?
importance?
One chocolate and get going to be
Otherwise, I'll get a chocolate.
Huh? Okay, nerve. He's pointing at the nerve.
Which nerve?
One structure which is still intact, which is kind of very difficult to reconstruct or recreate. How said that?
Yes, exactly. Who told that?
Oh, the one who was speaking here.
Keeping.
Some for hypoglycemia as well. Commissioner, the modulus.
So modulus is very difficult to reconstruct. If you open this up, how much ever suture you do, it is very difficult to reconstruct a modulus. So better to retain it, right?
Well, the
Sir?
facial nerve branches, if you connect everything, the small branches.
There are good chances that you might transect them as well, which was what he was showing like this. Every time when we ask people what are the branches of facial nerve, it's not just this, there is intracranial as well. So just don't.
Okay, so this I think Gunjan is the
Yes.
better person to answer.
So one of the cases that you had was something similar. So just very quickly because we are short of time.
So which approach?
How do you approach?
Do we have CT scan or something?
Yes, we do. So
Okay,
this is
so,
the.
so what is this most probably? What do you think is which kind of pathology? So benign or malignant first of all? Most looking like benign
Why
pathology.
benign?
Right? Yeah, why benign? Well defined. We want to say well defined.
Well different.
Okay, so the plan will be, before we plan incision, what is the plan? Your plan will be to go for?
See, we are not in the diagnosis of the tumor and all those things. We are
First
not
we need to
just
diagnose, then we
It's
plan
only
for.
the approach what we are discovering, like what we are discussing here. CCT, everything was done. It was benign. It was very well localized. Only the approach we want to discuss here. If such lesion, and that too two lesion. If you see, there is a orbital lesion as well in this eye and the mid face, contralateral eye and this mid face. So
What
such
kind of CT scan first of all? What kind of play? Why you want to go for contrast? Okay, anyone for another other than CT scan?
Contrast both.
CT, NG or okay, got it.
So again, I think everybody's best choice of approach was any difference of opinion in this?
Was the contralateral also approach for the same thing?
No, not this. It is approach with the lower eyelid approach. Not with. This is only for this tumor and that is with the lower eyelid approach, subciliary. Not subciliary. Orbital because the entire orbital content has been taken.
Anyone for intraoral approach for this case?
Yes. Because I think that because it can easily approach by the intern, but required experience. Only experienced surgeon can do.
Many ways to skip
Better
that,
to
I'm sure,
if you are young surgeon, better to go Weber profession.
It is still ITS,
But
sir. It
when
is
you have
extension
experience,
is
you
still
should go
pedagogy.
intraoral. This one.
It is still pterygoids. ITF is
No,
involved.
but this is not too much vascular like we are afraid of, because
for somebody who
there is no big vessels or directly the leg.
just with the mic idea. For somebody who does not deal with all these pathologies, I just want to know the approach, and I think we have.
We got the approach. Okay. That's fine.
That's
But not initially. Just one thing which Devi ji, just one thing which I want to just mention here. We are not talking here about the experiences. We are teaching you what to be. Somebody might have done this case with the endoscopic surgery also. So it's like it's a superiorly going lesion which cannot be removed with the intraoral approach, right?
Okay, so coming on to again buccal fat pad. What are the approaches you have taken? At least for minor, you must have done and taken out buccal fat pad. No? Yes? Somebody hold a mic and tell me. Of course. Okay, intraoral. So there is external approach also. For that internal, you can have all those things. So I think we need to go ahead. So mostly, which extension do we utilize in your mid-face or internal communications? Sir, how much buccal fat?
So I think we use buccal fat routinely in our cleft palate repairs. Whenever we have a lot of tension, we just carpet that area with buccal fat. We don't want gum to go in. And one of the tricks that we have realized, and this is something that is documented, is do not grip the buccal fat pad because the capsule gets violated. If the capsule gets violated, it does not get mucosalized the way it should. Then it just has just a layer of fat which gets atrophied very quickly. So when you are trying to get the fat, dissect around the fat. As soon as you see the fat, you dissect around the fat, keep opening up, the fat will prolapse. Once the fat prolapses into the oral cavity, it is passive. You can stitch it up to fix an oroantral fistula, or you can take it towards the midline in the cleft palate patient. So it's quite diverse that way, but it is the handling of the fat pad that makes it a very useless flap if handled poorly. So remember this vital thing. The capsule of the fat pad should not be violated as much as possible. So just keep dissecting around it, it will prolapse. These two words, if you know, you will be a very good fat pad surgeon.
Okay, how will you approach this kind of case? Yes, sir.
Just become introvert.
How? Which approach?
Carvalho, everybody knows Carvalho. That's brilliant. I don't know implants. Next.
Okay, this, how will you approach such kind of cases?
Which one?
Which approach introvert?
Cleans approach.
Cleans approach.
Next oral?
Gillies temporal approach. Brilliant. So next one will we've laid the trailer for the next talk also in between.
For such things, how do you approach mid-face? How? Vestibular. Okay, so here is again, I think sir will add.
I don't know anything about this. You
Again, you
can.
have a, yes.
There is a pan-shaped incision which starts from the midline, then it goes on the clavicle, and then it turns around the tuberotuberosity.
Exactly. So it's again your combination of clavicular and vestibular.
And also in zygomatic implants, no, you use buccal.
Sorry, sir.
True. We'll combine
I'm like
everything, sir.
Okay, that's it. I think.
Okay,
So
one last case can we take up? Okay, so a case of residual deformity, already operated twice, coronal flap already taken, mesh, rhinoplasty, everything has done. Patient is concerned about the hollowing of the this side of the eye. As you can see, this side is depressed and that side is ahead. You see, this side is depressed totally inside and this side has came outside.
So I'll give you a tip on approaching anything where there is a cranioplasty, and this is something that we need to know. So when you are doing when you are raising the scalp flap, right, you can get the scalp thicker or thinner. If you need the pericranium for some purpose, you end up making the scalp flap slightly thinner. But if you don't need the pericranium, obviously in this case they might have violated because they've entered it twice. You want the scalp flap to be thicker. So almost always err on the side of going almost to the bone when you are raising the flap again, because you want the flap to be thicker and you don't want to thin it out. The thinner the scalp flap, the more the metal will be exposed, or whatever you put in will be more visible or palpable if the scalp flap becomes thinner. And then of course there are so many ways to reconstruct that. I don't want to dwell into how you will reconstruct it. Of course that is probably what Afrin was looking at, but I think it's for the benefit of all of us, where in some of them may do it, some of them may not do it, only for understanding. When you are raising a scalp flap, think about what you need the scalp flap for. If you need the pericranium, you may make the scalp slightly thinner, make sure you have adequate pericranium flap. But in a situation like this where you're doing a reconstruction cranioplasty, you want the scalp as thick as possible.
So one small thing I want to ask. What is the difference, or what is the key tip you want to go to open a already operated or already open coronal flap? And second, is there any alternative for a
I'm always surprised and baffled how neurosurgeons don't understand vascularity as much as we do. Don't make an incision which is in a place which will compress a small or create another scar. So if there is a scar tissue and you make another incision parallel to it, that part becomes scarred as well, and that band of tissue dies. So if you can almost always go through the scar tissue. If you want to revise the scar, first cut it through the scar tissue, see how your flaps are going back and then cut the excess scar tissue. That means cut through the scar when you're raising it and then towards the end cut the scar tissue. Is that what you're asking?
Yes.
Yeah, that's
An
it.
alternative? Any other thing if you don't want to open coronal?
I think for this it might be very difficult. If you don't want to open, whenever you're doing any reconstructive plastic work, you're basically doing it for the aesthetics. You want to keep the aesthetic zones intact. If you put a direct incision anywhere, which is not in the previous incision, it might be problematic. Thank you. Any question? There.
If we go through the scar tissue, then
Yeah.
healing won't get affected.
No, that's all. You can freshen the margin, and the scalp is still a very vascular flap. So in craniofacial surgery, for instance, we end up going through the same scar flap multiple times because the child has had multiple ops. So we just cut a small tissue around that scar tissue to get the vascularity back. But technically, you don't want to recreate or no, recreate is the wrong word. You don't want to put another incision on another area. That's all. Any other question? Oh, he's got it.